So let's let Saad get us sort of caught up on that, because everybody may not know that those trials. And so let's do that one, and let's do the CASSIOPEIA as well, just sort of in a little bit of a nutshell.
Sure. So the FORTE trial, this was actually updated data only on response. The FORTE was a 3-arm randomized phase 3 trial with roughly 470 odd patients. Patients got either KRD continuously for 12 months or K with cyclophosphamide dex as induction for 4 cycles transplant and then 4 cycles of consolidation, or KRD for 4 cycles of induction transplant and 4 cycles of consolidation with KRD. I think that the key messages for me from this trial when I first heard it at ASH were the PI IMiD DEXA combination is probably the better combination. Many of us actually have always thought like that, but we actually had data to support it in terms of depth of response that patients get. The other message I kind of agree with, Amrita, sustained MRD negativity or sustained depth of response is what you get with addition of autologous stem cell transplant, and that's what we saw with the data being presented. The other study, the CASSIOPEIA, was a phenomenal effort by our European colleagues enrolling over 1,000 myeloma patients within 2 years, and then reading it out and presenting it to us, in record time. So this was a trial which randomized patients to VTD induction with or without daratumumab, followed by a similar consolidation before maintenance post-transplantation, showing the addition of daratumumab led to improved depth of response in patients. In fact, the paper just came out in Lancet. One thing that surprised me about this trial was the comment about stem cell mobilization, because we did not see that in Griffin. I'm not sure whether it is the lack of experience in mobilizing with just growth factors, but I'm not sure, because we don't see that signal when we use data with RVD, in clinical trial settings.
Yeah, I think at least one take-home message for me, and you may want to comment a little bit more on MRD, is that while we always talk about MRD, 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 the reality is 10 to the minus 5 is not 10 to the minus 6. And, PFS doesn't always match what the MRD data tells you. And so I think the transplant still continues to have an important role. And I sort of think about it as response is dependent on induction and PFS is dependent on maintenance. And that's really an important issue with CASSIOPEIA, that it was DARA versus nothing in the maintenance phase.
Right.
And no matter how you look at the randomization, the curves start to separate at about 9 months after diagnosis, which is around the time that you either get randomized to DARA or nothing. So I really wonder about the importance of some form of maintenance. I don't know what you all think.
No, I agree with you on that. I think that's a similar pattern, I suspect, what we'll see with Griffin as well. The response data that Peter Voorhees presented at ASH, just with all 16 patients, interestingly was, it wasn't, the depth of response actually improved post-transplant. I didn't see any differences between, what we know, what the kind of responses we get with RVD compared to DARA RVD just with the induction piece of that whole regimen.
I mean, sorry, this transplant, this preparative, or this therapy for transplant, I think one advantage to this is we are going to see what happens with maintenance or no maintenance, right? So we don't really know where monoclonal antibody will have its biggest splash, as part of induction, as part of consolidation, or as part of maintenance. This is the only trial that'll tell us as part of maintenance, right? Because it's against nothing.
Which, when you
I
say
don't think that's fair, because isn't it?
Yeah, CASSIOPEIA.
Because isn't it, you're still going to get DARA in your induction arm, though?
Well, there's going to be people that get DARA induction.
But don't get it as maintenance.
Correct, exactly.
There'll be 4 eventual subgroups of patients.
So it'll be interesting to see. I think we all believe that lenalidomide maintenance is a very important part of the post-transplant effect, especially even the immune effect that we've been talking about. And so this kind of therapy we wouldn't be given to patients, I think, in the US. But that said, this is going to provide some very important data for us.
I think the Perseus trial, though, is going to be the one that really moves our curve, right? Because that trial is RVD plus or minus DARA, which is obviously very reflective of the US, and then randomization to DARA lenalidomide versus lenalidomide alone, so very reflective of our practice. So I guess the question I would ask everyone, is everyone ready to immediately jump to DARA RVD based on CASSIOPEIA? Or
I don't think we can. I don't think we're going to be able to do that. But I do like Perseus also because there is an adaptive design built at the maintenance. So if they achieve MRD negativity, then they're going to have they're going to be able to stop the daratumumab continue len, and that'll be great because then maybe when they relapse, then you can put back on the CD38 antibody, which would be great.
can I put a plug in then for, at the risk of sounding like the Tonight Show, that we are going to have that option in the United States too with the SWOG trial that's going to open in July, which is also going to be any induction transplant and then randomization to DARA lenalidomide or lenalidomide for 2 years and then second randomization based on MRD. So hopefully we can, in fact, accrue quicker than our European colleagues this time and answer that.
I'm happy to jump on adding the DARA to a triplet bandwagon for standard risk patients. I'm still on the fence about the high risk patients in the frontline setting. If you look at those pre-specified PFS subgroup analyses on Maya, on LCON, even in CASSIOPEIA, the high-risk patients aren't really benefiting from the addition of daratumumab, and that's, maybe that will happen over time. Maybe that will happen with subsequent longer follow-ups. But at this point in time, I'm a little on the fence about the high-risk patients specifically.